I'm currently Head of Organisational Health and Effectiveness in a Northwest acute hospital. The research I did previously is in another Northwest acute hospital, and it's looking at, does leadership behaviour affect quality and safety in healthcare? Probably the easiest answer is yes to that, but there's a bit more to it, hopefully. So, as an introduction, the research focused on executive leadership behaviour, beliefs and the likely effects on quality and safety, identified what quality and safety meant to them and how it can affect performance, reviewed leadership styles and how to develop the most optimal style, and discussed the cultural aspects of quality and safety, how to achieve an efficient organisation and engage with staff, and process for the first publication and the future MPhil PhD, which we're starting on. So, process of research. Obviously, developing the question was probably the hardest thing. What was the question and how do I answer that? I used semi-structured interviews with 9 executives who are no longer in the organisation I previously worked for, because of the turnover within organisations is quite vast at executive level within the NHS. I think there was some information that said chief executive's lifespan was about 2 to 3 years within the NHS, which is obviously same with government, and changing leaders does have an effect on the organisation, as you can imagine. So put information into NVivo 9, we're on that NVivo 10 now, which I'll be using for my next lot, but that was really useful to identify the themes within the qualitative interviews that were undertaken. Applied to publish a paper, and if anyone wants to see copies of the paper, I have 10 copies here available, but I can send those copies to you if you'd like to have them as well. The research resulted in presenting at 4 major conferences, and the future research will focus on the CCGs. Obviously they've been in place since April last year, and my future research will look at how their behaviour influences quality and safety.
Tell people what a CCG
Oh, sorry, okay. A CCG is a clinical commissioning group, and they've been brought together to bring local issues regarding commissioning to the NHS. A lot of PCTs, primary care trusts previously, were centrally held. I used to work actually for Liverpool, and they believe they weren't getting the local needs. So the clinical commissioning groups have been established across all areas to manage now the commissioning process to deal with local needs. Okay. So the results of the research. Executives understood what leadership style was appropriate. The important issues to them included being honest, inclusive, supportive, and showing integrity. The leadership programme was not aligned to the strategic vision of the organisation. So the leadership programme was kind of separate to what the vision was of the organisation. Clear accountability and lines of control were required to ensure that staff were effectively educated and engaged. Executives saw themselves as transformational, and I suppose when you ask somebody how do you feel you would be as a leader, transformational is the preferred option because it's engaging and it shows integrity. They often wouldn't say that I shout at people and want to get targets, because that wouldn't look good. So they recognised the style would need adapting, particularly where we had to get targets met. The style of the Department of Health and commissioners set the tone for the organisation. So if targets were centrally driven, that had a huge effect on how the provider behaved. Transactional and autocratic leadership was often required in the achievement of targets. So if you're looking at waiting times, 18-week waiting times, 4-hour waits in A&E, that was a priority, and that may affect the quality and safety given because the focus is on the target. And there was a lot of movement of people to make sure you got the target, because that's what you got paid for, which is a risk to any organisation. So when we discuss quality and safety was often described as a single issue focusing on patient experience. And for me, for my background, which was health and safety enforcement, legislative compliance was also an issue. Safety was described as legislative compliance. Maybe that's because I was sitting there and they knew that I was head of safety. So that could have influenced the way they were talking. But a lot of the executives spoke about it differently. If you were head of an executive responsible for a state, you had a different view on quality and safety than a nurse manager. So as an organisation, if you're trying to promote quality and safety across the board, you may be getting different messages depending where you're sat. So the vision of executives was not clear for all staff to understand and to follow. So if the vision wasn't clear, which bit were they following? The external drivers for quality and safety included public expectation, which is going up. The public expect the NHS to be 5-star, waiter services, mini bars, not really, because you ain't going to get it. And again, it's about that cost. What is reasonable cost for quality and safety? The Royal's being rebuilt. I'm sure that will be, carbon free. But when they're looking at obviously, new facilities, everyone wants en suite. You want a toilet to yourself. Now that increases nursing capacity, because if you're in a separate room, you can't have the number of nurses that you need. So that needs to be built in as well, as all the other issues. Dr. Foster, there was a lot of information about mortality rates, and a lot of organisations have been targeted recently about their mortality rates and how they assessed figures as well. Financial penalties, monitor, and then more recently commissioning from GPs is now coming about. Quality and safety was described as being problematic in many cases, and one executive described it as being problematic in practical terms. Theoretically, it's a no-brainer. Why would you undertake practices that might injure people? And clearly, we don't want to injure people. But 1 in 10 people, according to the National Patient Safety Agency, is made ill by a visit to the NHS, who weren't in the first place. So that's a significant number. Someone did say, well, why were they there if they weren't ill in the first place? Which is maybe another question. Transactional management then. There was a recognition by the executives that the style may be used in a medical emergency. I don't mind being shouted at in a cardiac arrest situation. Now, speaking to some consultants in a cardiac arrest situation, that is actually the worst time to shout at someone, because you're already hypertense, and shouting, go and get this, and go, you actually will make more mistakes. So a calm atmosphere would be better, but there's an expectation that I could be shouted at in those situations. The style of Department of Health cascaded down the line. If there was a failure in target, you would get a kicking all the way down the line, and most of the executives said that, and that creates the behaviour within the organisation. Very difficult to have a stopping point from your commissioner, from your chief executives down the line to your staff, whereby you go, actually, that behaviour isn't appropriate, I need to stop that. Working to dictatorial bullying was most inappropriate style, yet most executives had either been a victim of bullying in the past, not within the trust they currently worked. Working to an autocratic manager was described as absolutely horrendous, as you imagine it would be. And the increase in safety incidents was described as commissioners would be very aggressive about intervening and stopping this problem. Now, this causes obviously a safety paradox, because you want to increase incident reporting, but if that gets to the commissioners, they will then say, what's going on? Why are you reporting more and more? You should be reporting less. But actually what you want to do is report more near misses and low incident issues rather than higher risk issues. So that, I suppose, is educating the commissioner that actually more reporting is good, because then you can stop the major issues. So leadership behaviour is differentially related to team performance. And subordinate maturity is vital to the effectiveness of the leaders. When subordinate maturity is low, leaders have to focus on structure. When the maturity is high, structure can be de-emphasized. So initially you would make sure that people understood what their role was. This is what we expect you to do. Make it very clear. Once that is clear and they're working within the boundaries of the project plan or what their role is meant to be, you can then de-emphasize and move away. But that takes a long time to develop that maturity within organizations. Transformational leadership, engaging, educating, showing integrity, increases higher levels of performance. There needs to be a strong narrative between the line of sight between the job role responsibilities and the organizational vision, so that individuals understand how they are contributing to that vision of the organization. There needs to be clear direction and behaviour from leaders to enact work behaviour. And some quotes from individuals. I've seen people where they have been people who have had this little clique mentality, particularly on wards. If you aren't in, you are out of it. The English wasn't that great. Your face doesn't fit. How sad that has made some people, and actually how it's driven people away because of they've been excluded. And often people were brought into the organisation because they want to change the culture, and the executives want to change the culture. But the leadership within a team is actually not the manager. Someone else has the control. And it may be someone who's got influence or has been there a while, and they create the culture. I've seen individuals reduced to tears on occasions, not distrust but bullying, very directive, lack of support, very demanding. You will do this, I don't care what you say, your head's going to be cut off if you don't achieve it. And then finally, a charge nurse on a ward wasn't just a bully, physically aggressive, and witnessed him assault patients and staff. That was 30 years ago in a mental health trust. So these are the type of things that people have witnessed within organisations and have got to executive level and seen these things. We can't obviously move away from the cultural aspects of quality and safety. The most ineffective way to individuals to change is through a transactional manner. It may take many years to change custom and practice, and culturally people may hear the message about finance and targets, and if you haven't got somebody on the executive board that is going for the quality and safety agenda, then finance and targets will be the key issue that's talked about. A good quality and safety culture can be easily eroded by the way leaders behave. I'm sure people, if somebody goes onto a construction site, picking on construction because I did a bit of construction work, and the manager doesn't wear a high-vis vest, well, what does that say to the staff on the ground? I don't need to do that. So that type of leading by example is very important. If quality and safety means different things to different people, which model will be followed? And culture is described as the way we do things round here. I suppose it's simple really. When teams members are made to feel like all they can do is fail, they won't try and succeed. And research from King's Fund identified that the NHS approach is pace setter, typified by demands, being reluctant to delegate, leading from the front and not collaborating. Targets have secured impressive improvements with shorter waiting times and better access for faster treatment. And that can't be denied. There was a reason for why targets are an important issue. And they have shown massive improvement within the NHS. But they have done so at the cost of leadership styles as affiliate, which creates trust and harmony. Highly performing leaders deploy a range of leadership styles, dependent on the demands of each situation that they may be in. Top-down culture is the prime cause of poor care. If senior managers impose a command and control culture, that demoralises staff and robs them of the authority to make decisions, and poor care will follow. Obviously, the Francis report identified issues with the commissioning side of things. The DOH, as a cultural leader, the evidence before the inquiry does not justify a conclusion that there is a factor culture within the Department of Health which could properly be described as one of bullying. What was evident was they established a well-intentioned decisions and directives emanating from the Department of Health have either been interpreted further down the line that hierarchy and bullying, or resulted in them being applied locally in an oppressive manner. And mid-staffs, that's what happened. They focused on targets and finance and just basically cut areas. And as you know, there were people that didn't have drinks and they were drinking out of vases, people who were having the faces shaved with a razor and then moving on to the next patient with that same razor, people going to the toilet in beds and things like that, due to the fact that there wasn't enough staff to manage that situation. So as we've seen from Francis, there are something like 220 recommendations from the Francis report that every hospital is now implementing. And the Francis report has really got a grip to some extent of behaviours within the NHS and has put them into policies, and we've got this more open culture that they're trying to develop where risks are escalated appropriately. So to be a good leader, focus on the team, inspirational, integrity, clear goals, good example, vision. And I suppose it's easy to say all these things, but when you are rushed off your feet and you know you've got 10 patients with a lot of needs and a lot of complex needs, because this is within a background of decreasing costs within the NHS. 20 billion will be taken out by 2015. The current budget is 106 billion. They're looking at taking another 20 billion out by 2020. So you're looking at a reduction in funding, an increase in obesity, elderly people, drug costs. The gas and electric bill for our organisations is going through the roof. The costs of staffing is going through the roof. The expectation of having more staff. It is extremely difficult in these financial times to keep on top of all of the elements together. And to continue to be a good leader is becoming more and more difficult, I'd suggest. But maybe that's why there needs to be more research into it. Yeah. Okay, so the policy implications, absolute commitment to targets and finance by the CCGs can increase the risk of organisational failure regarding quality and safety. We've got to recognise that the CCGs are new, less than a year old, maybe not as mature as the PCTs with their thinking and the way they work, but that's yet to be seen whether it has a good influence on quality and safety. Target-driven approach is important, but may sideline quality and safety if not handled appropriately. The aggressive pursuit of data may result in organisations underreporting incidents due to the fact that you may get penalised for reporting. And positive engaging behaviour that develops an organisational norm can improve quality outcomes for patients, staff and enhance performance. This picture kind of says that person who was driving that white line thing was not quite engaged with wanting to go the extra mile and move the little bit of tree out the way to have a straight line. And engagement is talked about a lot in the NHS now. The organisation I work for has got something called Listening in Action, where they go out and speak to teams, and the chief exec has open forums where they engage with staff and they look at issues that are causing blockages within systems, and it is a really good engagement process. I don't think it's embedded in a lot of organisations, but it certainly is where I currently am. Listening in Action, whereby they do take on staff's issues and try and address them as best they can. It's obviously the heightened emotional and intellectual connection that a person has for their work, organisation, manager and co-worker, in turn that influences them to apply discretionary effort to their work. And one of the problems with the leadership attitude and behaviour, where you are focusing on a transactional issue, people will just focus on that issue. They will not think outside the box. If you are demanding an issue to be addressed, people will deal with that and won't do anything else. And that's where engagement and maturity of the organisation is important. The correlation between the happiness of staff and organisation performance is closely linked. The extent to which staff are committed to the organisation and to their work is strongly related to patient outcomes and patient satisfaction. And this is another test within organisation, within the NHS now, is patient satisfaction and would you recommend this organisation to family and friends? And we're being assessed on that as another target. We need to develop a climate of trust and respect, and this is characterised through the top performing trusts within the country. So the implementation of the research, executives define the strategic vision of the organisation for quality and safety with clear values for the organisation. The leadership programme was evaluated and changed the behaviour of leaders within the whole organisation. A cultural survey tool was undertaken to evaluate the climate within the organisation, and the governance structure and process had a higher profile, and lessons learned was triangulated with claims and complaints and incidents so they could all be monitored together. Staff engagement strategy was implemented to get better clinical engagement. Published an article which I didn't think was possible, but sent it off and they quite liked it, and got published, so that was good. Then was asked to present at the scientific conference on performance strategy development of healthcare facilities in Riyadh, Saudi Arabia last year, and then went to another conference in Abu Dhabi, chaired and presented at the Middle East Patient Safety Congress. So me doing this piece of work has had some very positive results. Till we get to the next bit. It's got me interested in research. It's got me wanting to carry on, and just last week put me RD9 in through the process. Me ethics approval went off at the same time, and the question that I'm asking now is analysing patterns of behaviour that lead to effective quality and safety in healthcare, a commissioner's perspective, and I've set objectives which include defining the drivers of quality and safety, the reasons why appropriate behaviours are important within healthcare, analyse individual and group dynamics that can lead to poor decision making in healthcare, identify quality and safety, is it problematic within the CCGs and how may this affect the outcomes in provider services, and analyse the benefits of creating a behaviour-based tool that can be used for commissioners and providers within the NHS. That's the plan.
Good plan.
Good plan. So we're having an open forum with keynote speakers and inviting 24 members of the CCGs, and we're going to hopefully video them and look at their behaviours. We're going to do a quantitative questionnaire and then some semi-structured interviews with provider services and develop a behaviour-based tool. So I hope you found that interesting. Reviewed the research undertaken and determined transformational leadership is more effective but difficult to implement. Culture is often difficult to define but directly related to influence quality and safety outcomes. Clear vision is the key to success, and leaders' behaviour influence patient and staff safety at all levels, and clear engagement with staff will increase productivity and performance, and identify process for research and how it can use to improve performance and moving forward to complete the PhD in 5 years. Any questions?
Excellent. Thank you very much.